What happens when Washington turns to tariffs in the middle of America's obesity crisis? A new policy out of the White House has patients asking if GLP-1's cost could climb even higher. Then we'll break down a split federal court decision and Lilly's lawsuit over compounded tirzepatide and why it could change how telehealth companies advertise their drugs. And later, new research offers the first real evidence that weight loss maintenance without medication might be possible, a development that could reshape what long-term treatment looks like.
Hey everyone, welcome back to the Downsize News. It's Monday, September 29th, 2025. We hope you're having a great week so far. Today we're diving into the latest on GLP-1s. I'm Lorraine Durham and I've lost 50 pounds with the GLP-1 drug tirzepatide. This journey has changed my life and I'm here to help you feel informed, empowered, and supported every step of the way. So if you're ready for the latest news from the GLP-1 world with a little splash of motivation, stick around here for updates you may not see anywhere else.
I'm Christopher Durham and I've lost 100 pounds on this adventure with GLP-1s. What we share here is real experience, not theory. We're here to share the real story about the medications that changed our lives, the news shaping our access, the challenges along the way, and the science bringing new options.
If you're new to our channel, welcome. And if you've been with us for a while, welcome back. Well, we always like to remind everyone that we're not doctors and this is not medical advice. However, we have lost weight with the help of GLP-1 medications. We share videos on GLP-1 topics every single day, so make sure to hit that like and subscribe button so you don't miss an episode.
From Mounjaro and Zepbound to Wegovy and Ozempic, from semaglutide to tirzepatide, and even the new GLP-1s in development, we cover it all. From the latest research and policy changes to new medications on the horizon, we're here to break down what really matters for those of us treating the disease of obesity with GLP-1s. Before we begin, just a quick reminder, we are not a political channel. We cover the intersection of GLP-1 and politics, but please keep the comments respectful. Our fight is against the disease of obesity, not each other. So as you can imagine, story number one has some politics in it.
You don't say. In story number one, the cost of treating obesity with GLP-1s has never been easy to shoulder, and now there's a new reason for concern. Out of Washington, a policy shift has sparked fresh questions about just how much higher those costs could go. Late Thursday night, President Donald Trump posted this message on Truth Social. Quote, "Starting on October 1st, 2025, we will be imposing a 100% tariff on any branded or patented pharmaceutical product unless a company is building their pharmaceutical manufacturing plant in America. Is building will be defined as breaking ground and or under construction. There will therefore be no tariff on these pharmaceutical products if construction has started." End quote. The White House later clarified that even projects already underway, including those launched before this administration, will qualify for an exemption. Medicines have long been spared from trade wars, precisely because taxing them risks higher prices and shortages. This announcement breaks with that precedent. For patients relying on GLP-1s to treat the disease of obesity, the question is clear. Will this policy make already expensive drugs harder to afford? Wall Street, however, responded with calm. U.S. pharma stocks rose. Pfizer, Lilly, and Bristol Myers all posted gains. European companies like AstraZeneca and Sanofi closed higher. Only Asia drug makers saw steep losses, with Japan's Chugai and Sumitomo each down more than 5%. The reason? Many large companies already have U.S. construction underway. Novo Nordisk, the maker of Wegovy and Ozempic, has multiple U.S. investments in motion, including a large expansion in Clayton, North Carolina, and a manufacturing hub in New Hampshire. But the policy comes with carve-outs. Generic drugs are excluded, and trade deals with the European Union and Japan remain intact. Both regions negotiated a ceiling, a 15% tariff cap, on pharmaceutical exports to the U.S. That protection matters for GLP-1 patients. Denmark's Novo Nordisk, as part of the EU, is shielded from the 100% rate. European officials called it an insurance policy, guaranteeing no higher tariffs would be applied to their drug makers. For patients, that means medicines coming from companies like Novo Nordisk in Denmark and Sanofi in France should remain largely protected from the sharpest impact of Washington's trade war. The industry trade group Pharma praised the pro-investment climate but warned every dollar spent on tariffs is a dollar that cannot be invested in American manufacturing or the development of future treatments and cures. Other analysts suggested the move may be more political than practical, more about showing progress on drug prices ahead of the midterms than reshaping the supply chain. And what about compounded medications? Compounded tirzepatide and semaglutide are not directly included in these tariffs. The order specifically targets branded and patented imports. Compounded GLP-1s are prepared inside U.S. pharmacies, not imported as finished drugs. But many pharmacies rely on imported active pharmaceutical ingredients, or APIs, from abroad. India alone supplies nearly 47% of U.S. pharmaceuticals, mostly in the form of generics and bulk ingredients. Right now, generics are excluded, and APIs haven't been named in the tariff language. But if they are swept in later, compounding pharmacies could see costs rise. For now, that means compounded GLP-1s remain the lowest cost option. But just like the branded versions, they are not completely insulated from Washington's trade war. For the administration, this is a political signal about bringing jobs and drug production back home. For Wall Street, it looks manageable. But for patients, especially GLP-1 users already paying thousands of dollars each year out of pocket, the uncertainty feels heavier. The real question is whether tariffs will truly lower drug costs or whether patients will once again be the ones left paying the price.
So it looks like both Lilly and Novo are not going to. Lilly, of course, is a U.S.-based company, but they have production around the world. Novo has factories here. They shouldn't be impacted. I think the challenge for GLP-1 users is so often we have comorbidity. So we're not just taking those, we're taking a lot of other things. Mm-hmm. And those other drugs could go up in price depending on where they're manufactured, who owns them.
That's true. So anytime there's a tariff applied and costs go up, those are generally passed on to the user. But Zepbound, Wegovy, Ozempic, Mounjaro, those should not have a price increase due to these tariffs because they shouldn't see these tariffs. Maybe compounded will in the future, but for now they're not included, so we're not going to worry about that for now. We got plenty of other things to worry about.
Well, I don't really understand. So like Novo Nordisk has factories here for Ozempic, Wegovy. They also have factories overseas. I don't know if they're leveraging the overseas factories to bring additional product in, and if that product would be impacted.
They have a factory here, they're not included.
I don't know if there's a distinction if it gets imported in, if it matters. It's hard to tell based on the language.
There's nothing clear about this language, to be sure.
Story number 2, if you're following the lawsuits over compounded GLP-1s, a major decision just came down in federal court this past week. On September 24th, 2025, Judge John Tigar of the United States District Court of the Northern District of California issued a ruling in Eli Lilly and Company versus Adonis Health, Inc., better known as the case against Henry Meds. And while the case is about one company, the order goes much further. It strikes right at the heart of how telehealth platforms advertise compounded tirzepatide. Here's the split. Judge Tigar threw out Lilly's claim that Henry's compounded tirzepatide was falsely advertised as safe and effective. He said Lilly's argument was really just about a lack of substantiation, and that's not enough for a false advertising claim. But on the other side, the judge allowed Lilly to move forward on its claim that Henry misled patients by calling its drugs personalized, tailored, or patient-specific. He found Lilly had plausibly alleged that those claims were literally false, noting that Henry in fact offered a standard treatment plan where each patient would receive the same pre-made dosage of tirzepatide over the same amount of time, regardless of individual circumstances. Judge Tigar was clear, FDCA compliance doesn't matter if the advertising itself is misleading. He said terms like patient-specific, tailored, or individualized treatment would lead a reasonable person to believe that Henry was creating unique medication plans for each patient. Since Lilly alleged that wasn't happening, the claim moves forward. So where does this leave us? It's a classic split decision. Lilly lost on the safe and effective claims, but won on the personalization issue. That outcome allows Lilly to keep pursuing part of its case, and it may influence how other courts view similar advertising disputes involving compounded GLP-1s. And it's important to remember this is only the next step in what could be a long, drawn-out legal process. Cases like this can take years before reaching any final outcome. For patients, here's the takeaway. This ruling does not decide the future of compounded GLP-1s. It only decides which claims can move forward. It means telehealth companies will face scrutiny if they advertise compounded tirzepatide as personalized, when in practice it may not be. And it gives Lilly a precedent it has already asked another judge to consider in its case against Mochi Health. For patients using Zepbound and Mounjaro or compounded tirzepatide, this case isn't about whether the meds exist. It's about transparency and how they're sold. In other words, what matters is whether the advertising is truthful, not just whether the FDA has spoken. We'll keep tracking this closely because these legal battles shape the future of access, affordability, and trust in obesity treatments. So, there's a whole lot of cases out here, and this is just another baby step forward. Basically, Henry Meds had asked the judge to dismiss everything, saying and the judge came back and said, yeah, I'm not going to dismiss everything, but they have a point here.
Now, when Henry Med said that they are personalized and patient-specific, well, what does that really mean if they're giving everybody a 16.6 milligram dose instead of a 15.0 milligram dose? Is it really patient-specific when you're giving everybody the same different dosages?
Same drug, same treatment plan.
Yeah. So this is where compounders really need to take a look at how they're prescribing, and they do truly it needs to be individualized to the patient. And I would say less in your advertising. Say less, smile more, in the words of Lin-Manuel Miranda.
Yeah, I think this is really coming down to how they're going to market and what they're saying in their advertising, and then whether they actually are personalizing things. And I think the judge is probably right here, so it's not like the judge was crazy. If you look at Henry Meds' advertising, they were selling the same thing to everyone.
Well, and they can also make it personalized by a different dosing schedule. For example, staying on a dose longer than 4 weeks would be personalizing it. So in that way, it's personalized. Adding another drug along with the compounded medication, such as a bupropion or a NAD+, we're seeing a lot of the compounders add to their list of available medications, might be a way to personalize it to each
There's ways
patient.
to do it. I just don't know that Henry Meds is.
We've never used Henry Meds, so I'm just thinking, how could a compounder truly provide personalized medication for their thousands of patients?
So to me, if you're using a telehealth company, I would first of all look at it. If you are not talking to a real doctor who is then
or a
creating a
licensed
personal
nurse practitioner,
right, or someone who can legally prescribe, someone who is actually helping you personalize your plan,
right.
That's probably a red flag at some point that telehealth is going to have an issue legally. And I don't see any way to defend that.
Right, because there's still prescription medications.
Mm-hmm.
So if you're not talking to a doctor before you're getting these compounded medications, definite red flag.
I don't know
or
how that.
Licensed nurse
Yeah,
practitioner.
I don't know how that's going to move forward. All right. Anyway, we'll keep reporting on this because these court cases are going to take years. Nothing moves fast in the American system.
If you're treating the disease of obesity, you already know the truth. GLP-1 medications are powerful tools, but they're treatments, not cures. For most of us, when the medication stops, the weight almost always comes back. That's been the reality until possibly now. New data released this week may point to a different future for maintenance. A company called Fractal Health has been studying a one-time endoscopic procedure called Revita. It targets the lining of the small intestine, aiming to reset the gut's signaling pathways that are disrupted by years of high-fat and high-sugar diets. Here's why this is getting attention. In the Remain-1 study, patients who lost at least 15% of their body weight on tirzepatide stopped taking the drug. At that point, they were randomized to either receive Revita or a sham procedure. 3 months later, the Revita group went on to lose an additional 2.5% of their body weight. The sham group, they regained 10%. Womp. That difference is not only striking, it's statistically significant. And it wasn't just about weight. The procedure was safe, well tolerated, and consistent with earlier studies. No serious side effects linked to Revita were observed, and the few minor ones were short-lived. This raises an important possibility. Could there one day be a tool to help preserve weight loss without the need to stay on GLP-1 therapy forever? Dr. Shelby Sullivan at Dartmouth called the results the first controlled evidence that drug-free weight maintenance may be possible. Of course, this is still early. There are 3-month midpoint results. 6-month data are expected in early 2026, and a larger pivotal study is ongoing. But for patients treating obesity, the message is clear. Maintenance may not always mean going back on medication or bracing for inevitable regain. There may be other options ahead. Fractal CEO described it as moving from chasing weight loss to sustaining health with what he calls a durable metabolic reset. It's too soon to say whether Revita will become a standard part of obesity care, but for those of us living in maintenance, it's a reminder that science is evolving and the future may include more choices to help us hold on to the progress we've worked so hard to achieve.
We've reported on this along the way a couple of times, and if I remember correctly, this is essentially like cauterizing.
So they stick a tube down your throat.
And they burn it a little bit.
And they do something
Well, it may go up
to
the
your
other end. I'm not sure which end it comes.
Oh.
Yeah.
Endoscopy,
Not sure.
colonoscopy.
Somehow it gets in there, yeah.
I think the endoscopy goes this way. I'm
Yeah.
not a doctor. But it goes down to your small intestine and does something there.
I'm
does
pretty
a
sure
procedure there.
It burns it a little bit, and
I guess it would depend on the cost, the effectiveness, the long-term results. I mean, a 3-month study is what they have now, and it looks good, so they're going to study it more. So we'll stay tuned.
well, 3 months. I mean, you still have carryover from the drug for at least the first 30 days.
Well, they said they stopped taking it, so and they didn't say the gap in between there. So I guess it was a short enough time to where they weren't gaining any weight back.
Yeah. Story number 4, if you've been following the future of obesity medicine closely, here's a development worth noting. Eli Lilly has just terminated one of its clinical trials, combining Zepbound, their blockbuster GLP medication, with an investigational muscle-sparing drug called bimagrumab. This was a phase 2b study looking at patients with both obesity and type 2 diabetes. The company says the decision was made for strategic business reasons. A Lilly spokesperson told Clinical Trials Arena, "We routinely evaluate our clinical development programs to optimize the potential for each product." Now here's the key point for patients. The obesity plus diabetes trial is being discontinued, but the obesity-only trial pairing Zepbound with bimagrumab will continue, and results from that study are expected in 2026. Why does this matter? Because muscle loss is one of the biggest concerns for patients using GLP-1s. As the pounds come off, preserving lean mass is critical. That's what made this combination interesting in the first place. Bimagrumab was originally developed by Novartis and MorphoSys to treat muscle-wasting diseases, but it didn't succeed in that setting. Versantis Bio picked it up in 2021 for $70 million and shifted its focus, seeing potential in obesity care. Their bet wasn't unfounded. In fact, the BELIEVE study, which combined bimagrumab with Novo Nordisk's Wegovy, showed patients could lose fat while better preserving muscle compared to either drug alone. Those results were presented at the American Diabetes Association's annual meeting and drew a lot of attention. So even with Lilly halting this particular trial, the door isn't closed. The obesity-only study could still show promise, and for patients who worry about muscle loss on GLP-1s, the concept of pairing these therapies together is not going away. Analysts forecast the obesity drug market could reach more than $173 billion by 2031, and combinations like this may play a role in shaping the future. For now, Lilly is pulling back on one front, but continuing to explore whether Zepbound and bimagrumab together can deliver not just weight loss, but healthier weight loss. That's exciting. Everybody's worried about muscle loss.
Whenever you lose weight on anything, any plan, with fat, you also lose muscle. So the trick is, how do we maintain our muscle while losing weight? And if this drug could be added to tirzepatide and help maintain that, then that would be great. In story number 5, Eli Lilly is betting big on the future of obesity medicine. The company has announced plans to build a $6.5 billion pharmaceutical facility in Houston, Texas. The site will rise at Generation Park, just northeast of downtown, and when it's complete, it will employ more than 600 people and create 4,000 construction jobs along the way. Why does this matter for the future of obesity care? Because this facility will produce orforglipron, Lilly's pill version of a GLP-1. Lilly expects to file for approval for obesity later this year, and if it's cleared, this plant will be where much of the supply is made. The Houston project is part of a larger $27 billion plan to expand manufacturing in the United States. Just last week, Lilly announced a $5 billion site in Virginia, and 2 more mega sites will be revealed by year's end. All are designed to build capacity not just for obesity drugs, but for cancer, heart disease, immunology, and neuroscience treatments. There's also a competitive edge. Novo Nordisk already produces its oral version of Wegovy end-to-end in North Carolina. By planning routes in Houston, Lilly is creating its own U.S. to U.S. supply chain for orforglipron. That means faster, more secure access, and potentially fewer shortages for patients. Houston was chosen from more than 300 applicants thanks to its workforce, infrastructure, and business climate. Texas officials call it one of the largest pharmaceutical manufacturing investments in U.S. history. And it's part of an even bigger wave. Johnson & Johnson, AstraZeneca, Roche, Sanofi, and Novartis have each pledged tens of billions of dollars to build out U.S. production. The bottom line, the future of obesity medicine isn't just being researched in labs, it's being built right now in places like Houston and Virginia. And this facility could be the key to getting Lilly's first GLP-1 pill into pharmacies across the country.
In translation, they're not going to be out of stock on this.
Lilly is betting big on orforglipron. Hopefully it'll get fast-tracked, it'll get approved, and they will have supplies ready when the floodgates open of demand.
Well, we know they already have a reserve of it.
They've said that. They're stockpiling it. It's on shelves and ready to go out as soon as they get approval.
Yep. Story number 6. If you've been following our coverage of orforglipron, like in the last story, here on the downsides, do you know how big this pill could be? Eli Lilly's experimental oral GLP-1 is one of the most anticipated drug treatments on the horizon. And while most of the headlines are here in the U.S. are about when it will launch in our market, Lilly just made clear that its ambitions go far beyond America. According to Reuters reporters Rishika Saddam and Kashish Tandon, Lilly plans to launch orforglipron in India. Winslow Tucker, the president of Lilly India, put it plainly at an industry conference in Mumbai. There is promise for products like that in India if it gets approved. He didn't offer a timeline, but that statement alone signals just how central India is to Lilly's global plans. Why India? Because it is the world's most populated country, home to more than 100 million adults living with diabetes and facing a rising tide of obesity. And yet injectables like Zepbound and Wegovy have faced resistance there. Reuters quotes Novo Nordisk's India head, who explained why people in India would take their tablets rather than inject. He added that stigma and logistical hurdles weigh heavily on injectables, though he also acknowledged we are seeing growing acceptance of obesity injectables in India. That tension between rapid growth in demand and the cultural preference for pills over shots is exactly why Lilly believes orforglipron could be transformative. And there's another layer. Pills like orforglipron do not require refrigeration, needles, or special delivery. That means they could be manufactured, stored, and shipped more easily than injectables. If priced appropriately, they could also expand access and potentially bring costs down, making GLP-1 therapies available to far more patients in a country where affordability is often the biggest barrier. While Lilly has not yet said whether India's regulators have begun the approval process, the company is also preparing filings in the United States, the United Kingdom, the EU, Japan, and China. That's a global strategy with India right in the center. For you and I, treating the disease of obesity, this isn't just about convenience. It's about access, it's about choice, and it's about the possibility that a new generation of GLP-1s could reach beyond wealthy markets into places where the need is massive, but the barriers are higher. While orforglipron may be hotly anticipated here in the United States, India may be where its impact is felt most immediately and most deeply.
I think the whole world's waiting for orforglipron. at this point.
I think what happens is because you have so much of India is rural, and electricity and refrigeration are going to be an issue no matter what. And they have extremely high temperatures across the country. Getting this medication out in
High
a pill.
temperatures, for sure. Yeah, and the cultural preference. I mean, and who, I think most people would prefer a pill over a shot. Now, I know some people love their shots, and we'll stay with those, but I certainly would prefer a pill over a shot.
Okay.
And story number 7, if you're a patient using GLP-1s, you already know the cost is staggering. For many, it's hundreds and sometimes more than $1,000 out of pocket every single month. And now, new research published in JAMA warns us it's about to get even tougher. Out-of-pocket costs are climbing sharply in 2025, and prior authorizations, the roadblocks that stand between you and your prescription, have gone from rare to nearly universal. Between 2020 and 2023, only about 3 to 5% of GLP-1 prescriptions required prior authorization. But by 2025, that number has jumped to almost 100%. In other words, nearly every GLP-1 prescription now requires a prior authorization. That means more paperwork, more back and forth with your insurance company, and more delays before you can get your shot. The study also shows just how steep the costs have become. For patients in standalone Part D plans, the average monthly out-of-pocket cost was $99 in 2024. By 2025, it had risen to $175 and is now pushing close to $196 per month. That's almost a doubling in just a single year. For those in Medicare Advantage Part D plans, the numbers tell the same story. Monthly cost climbed from $52 to $64 in 2024, and then jumped again between $93 and $100 in 2025. So why is this happening? A big factor is the Inflation Reduction Act, signed into law in 2022. On the surface, it looks like a win for patients. Starting this year, the law capped annual out-of-pocket drug spending for Medicare patients at $2,000. But here's the catch. To pay for it, the law shifted far more of the cost burden to insurers. Part D plans that used to cover just 15% of spending once you hit catastrophic coverage now have to cover 60%. Faced with that much bigger bill, insurance companies are tightening access, raising coinsurance, and imposing prior authorization on expensive drugs like GLP-1s. And this is all happening at a time when spending on GLP-1s has absolutely exploded. Since 2018, costs in this drug class have grown by more than 500%. Prior authorization for GLP-1s became almost universal, and out-of-pocket costs rose substantially in 2025. Given the budget impact of these drugs, ensuring patient access and affordability is going to remain one of the biggest challenges ahead. For those of us on these drugs, these aren't just numbers on a page. This is about whether you can afford to keep treating the disease of obesity or whether the roadblocks become too much. So let us know in the comments. Have prior authorizations or rising costs slowed down your access to GLP-1s this year?
Story number 8, Walmart is taking a big step into specialty pharmacy delivery, adding refrigerated and reconstituted prescriptions, including GLP-1s like Ozempic and Zepbound, to its same-day service. With this expansion, the company says it can now deliver 90% of all prescriptions it fills, a major leap from where it was just a year ago. This matters because refrigerated and reconstituted medicines already make up about 30% of Walmart's $32 billion in the United States pharmacy sales. And for patients, it means that the same truck dropping off groceries or household supplies can also bring a life-saving or life-changing injectable on time and kept cold the way it needs to be. Walmart calls itself the first retailer to combine refrigerated prescription delivery with everyday essentials in one order, but rivals are quick to remind customers they've been here for years. Amazon says its pharmacy has shipped refrigerated medications, including GLP-1s and insulin, since 2020. Walgreens and CVS Health also operate large specialty pharmacies with delivery options, and even some grocery chains are in the game. What makes Walmart's entry significant is its scale. Millions of Americans already shop there weekly, and the company sees an opportunity to meet patients where they are. Kevin Host, Walmart's Senior Vice President of Pharmacy, said the expansion is about listening to customers and broadening access to critical medications. For Walmart, it's a chance to capture more of that fast-growing market. For patients, it could mean fewer missed doses, less stress about refrigeration, and a bit more convenience in a healthcare system that often feels like anything but.
And story number 9, if you're a patient using GLP-1s today, the question on your mind is simple. Will my insurance still cover it next year? For Excellus Blue Cross Blue Shield members, we might have some answers. The Rochester-based insurer is clarifying that drugs used to treat diabetes will remain covered. But starting January 1st, 2026, 3 GLP-1s prescribed specifically for weight loss, Wegovy, Zepbound, and Saxenda, are coming off the list for certain plans. Excellus isn't closing the door completely. Current members already using those medications will continue to have coverage if they meet the company's criteria. Doctors can still file an exception as long as the prescriber can prove the patient qualifies under the rules. The insurer says the decision came after a review by its Pharmacy and Therapeutics Committee, which includes community physicians and pharmacists. They say the concern is cost. Spending on weight loss GLP-1s has surged since 2021, and research shows that 58% of people prescribed them stop taking them before reaching a level of weight loss that improves their health. In their statement, Excellus said, "We are concerned about the limited number of members who would benefit from this weight loss drug, along with the medication's increasing costs." They emphasize that the changes are about balance, ensuring access for those most likely to benefit, while also offering members support with nutrition and fitness programs through their providers. So for Excellus members, the message is mixed. Yes, diabetes treatment remains covered. Yes, exceptions are possible, but weight loss coverage will tighten in 2026 as the insurer looks to rein in costs.
Notice they're not actually adding services to help patients be successful on these medications.
Maybe if they offered a little bit more support to those
So what
patients.
I'm saying is they have diet and nutrition plans, but they don't actually have personalized plans that say, okay, Christopher, let's help you make sure you're successful on this.
Here's a nurse line, here's a dedicated doctor you could email. Yeah, a lot of things they could do there.
Story number 10, if you're using GLP-1s, the business side of these companies matter because what they do behind the scenes can impact access, affordability, and the information that gets to doctors. According to reporting from Maggie Fick at Reuters, Novo Nordisk, the maker of Wegovy, has cut its U.S. sales team that focused on obesity and diabetes education for healthcare providers. The group, known internally as cardiometabolic educators, included several hundred staff members. Sources told Fick that the team was disbanded last Friday and employees were instructed to cease work this month, though they will remain on payroll until the end of the year. A Novo spokesperson declined to provide details on the specific roles affected, but told Reuters, "This process takes time and our highest priority is to support our employees." This move is part of a larger restructuring under Novo's new CEO, Mazir Mike Dudstar, which will include 9,000 job cuts worldwide. Fick reports that investors initially welcomed the decision, helping Novo's stock recover after losing more than $400 billion in market value since the middle of last year. One source told Reuters Lilly does not have an education team and Novo has decided it doesn't need one. On LinkedIn, multiple Novo employees confirmed they have been displaced, with one writing that the entire U.S. cardiometabolic education team was eliminated. As Maggie Fick notes in her reporting, big pharmaceutical companies often use these kinds of disease state education teams to raise awareness of medical conditions ahead of product launches or label expansions. Without them, patients may wonder whether their doctors will have fewer resources. So basically they had a team of people educated in this that went out to your doctor and said, "Hey, did you know Ozempic does this?"
And now they've all gotten fired.
Well, along with, another 9,000 people.
I don't understand why Novo, still being so profitable, saw the need to eliminate 9,000 jobs.
The problem is the new CEO hasn't revealed any long-term plan. They're just they're just executing against a plan they must have. So we can't see what, it could be, I have worked for companies who went in and laid off large numbers of people because they decided their path was in a different place. Mm-hmm. And they would lay off this people because they weren't appropriate and then hire people later to better fit their path. We just don't know what the We don't know what they're going to do.
In story number 11, in San Diego's Torrey Pines, Eli Lilly has just opened the door to its newest Gateway Lab site, an 82,500 square foot hub designed to give early stage biotech companies the lab space, the guidance, and the collaboration they need to push medicine forward. On the surface, it's a very nice new building, but for patients treating the disease of obesity with GLP-1s like Zepbound and Mounjaro, it's part of a much bigger story. Innovation doesn't happen in a vacuum. It happens when small, hungry startups get the chance to work shoulder to shoulder with big pharma scientists, sharing equipment, knowledge, and hard-won experience. I think JoJo agrees. Lilly's chief scientific officer, Daniel Shravansky, put it this way: the future of medicine depends on combining the strengths of academia, biotech, and large pharma to solve some of the most difficult diseases facing patients. And that future might mean the next GLP-1 or the next drug that helps maintain weight loss, or maybe something entirely new we can't even imagine today. This is Lilly's fourth Gateway Labs in the U.S., joining 2 in South San Francisco and 1 in Boston. Since the model began in 2019, companies that started in these spaces have already raised more than $2 billion and launched over 50 therapeutics and platforms. The San Diego site adds another 15 companies and more than 250 researchers into that mix. And here's why that matters for us. The medications that we use today, Zepbound, Mounjaro, Wegovy, Ozempic, are powerful tools, but they're not the end of the story. The science of obesity is still unfolding. We need more options, more innovation, and more ways to bring costs down. Facilities like Gateway Labs are designed to accelerate that process by turning ideas into real treatments faster. Julie Gilmore, who leads Gateway Labs globally, said the approach is hands-on. Lilly starts by asking every startup, how can we help? That kind of partnership could be what brings the next generation of obesity care to life. So while this is news about a building in San Diego, the ripple effects could reach every patient who's been waiting for better tools, more affordable treatments, and new hope in their own adventure with obesity. What do you think, JoJo?
JoJo says, I love innovation.
JoJo says, do they make Ozempic for kitties? I don't think so, JoJo.
No, JoJo doesn't need Ozempic. Are you crazy?
JoJo doesn't need it. JoJo is a very small and petite kitty.
Svelte. She's svelte.
Right, JoJo?
That wraps up this edition of the Downsized News. If you found it helpful, we hope that you'll subscribe to our channel.
And if you're looking for things that can help you with your GLP-1 journey, visit our website at thedownsized.org. There you'll find links to our 2026 Downsized Cruise, our GLP-1 Amazon store, and our email list. Please note we are Amazon affiliates, and when you shop through our store, you're helping support our channel at no cost to you.
If you haven't yet, give this video a like, subscribe to The Downsized, and tap the bell so you never miss what's next. We'll keep you up to date on the latest news, break down the science so it's easy to follow, and share our own adventure along the way. Come be a part of the Downsized community.
I'm Lorraine Durham.
And I'm Christopher Durham, and we are The Downsized.